Ladies and gentlemen, it's a privilege and honor to welcome Dr. Gaston Nyirigira. I'm sorry if I didn't get that right, but I tried to pronounce it in my head for a lot of time. He's a MD, MMED, FCA, ECSA, a distinguished senior consultant anesthesiologist and pain specialist at King Faisal Hospital in Rwanda. Dr. Nyirigira serves as the head of anesthesia and critical care and holds the position of senior lecturer at the University of Rwanda. Dr. Nyirigira's professional journey has been characterized by profound commitment to addressing acute and chronic pain management, particularly in low and middle income countries. His dedication to improving the quality of life of patients facing pain has driven him to pursue additional training in pain management beyond his background in anesthesiology. Can we please mute ourselves for now so that everybody can hear his bio? In the realm of pain management, Dr. Nyirigira has identified and tackled various barriers that hinder effective treatment, especially in resource-constrained settings. His insights into the challenges faced by patients and healthcare system in low and middle income countries have been instrumental in shaping the approach of this critical issue. Dr. Nyirigira's dedication extends to the field of chronic pain management, where he is a strong advocate for non-pharmacological approaches. He recognizes the limitation of medication-based treatment, often driven by affordability concerns in limited resource settings. His focus on lifestyle changes as an integral part of pain management demonstrates a holistic and patient-centered approach to care. One of Dr. Nyirigira's core beliefs is that the prevailing mindset surrounding chronic pain management can and should evolve. He envisions a future where pain management is not solely reliant on medication and where patients have access to affordable, effective, and comprehensive care. We are privileged to have Dr. Gaston Nyirigira as a speaker for this TORG webinar, where he will share his valuable insights and experiences in the field of pain management. His dedication to improving the lives of patients and advancing the understanding of pain management is an inspiration to us all. Please join me in welcoming Dr. Gaston Nyirigira to the TORG webinar, where we will undoubtedly benefit from his expertise and passion for improving pain management in healthcare. Ladies and gentlemen, I give you Dr. Gaston Nyirigira. Dr. Gaston, over to you, sir.
Thank you. Good evening, good morning, everyone, wherever you are. Do you hear me?
Yes.
Yes, we can.
Yes, you can.
You hear me? Okay, great. Thank you. Thank you for the introduction. This is amazing. Sometimes you don't know it's you people are talking about. And I'm really privileged to be with you and this participation on this webinar. In the field that I do love, I do like, and that I know it's really less addressed and very, very sensitive. So welcome to this presentation. I like the topic because it's saying Unveiling Multimodal Analgesia in Postoperative pain management. How can we bridge the gap between low and middle income countries and high income countries? So this will be, I'm sorry I'm at the airport, and that's why I proceed this time to present, and we have some sound around me. So my apologies. So we'll be talking about what is multimodal analgesia. That's the first question. And why do we need that in a post-operative period? and what are the components? What are the challenges in LMIC and what is the way forward? What can we learn from this? And then we finish with. We have a straightforward presentation, and I will share my experience, and some of you know how the journey we have gone through. And this will maybe highlight some of the issues that we can overcome in the future. Because I know everyone who participated wants to move forward and wants to have some change. So, what is multimodal? Everyone will ask that question, and then it's just the entity. Like everyone will think it's only using opioids or using other methods, but it's combined. That it has multimodal. So, which is where we want to focus on. So in the last year, like this spinal or video or peripheral nerve block, we can have local infiltration and then other systemic medication. And then the other question will be why do we need this? So I know some of you know what is the enhanced recovery surgery. That is something everyone is trying to focus on, something that involves preoperative, perioperative, and postoperative. There are a lot of things that have to be done before surgery, and then during surgery, and in postoperative. So we do this because we have done patients who develop complications after surgery, and then people think they have done a good job in Perioperative, but afterwards, no one cares. Just give normal medications, and then you think the job is done. It's not really true, because we have samples of patients who have got atelectasis, who have got pneumonia, ARDS, and the lady won't hear in the hospital says, you know, pain memorized instead in the brain, and nothing will change that. Then we have the constant complication, anxiety, depression of those patients who were operated successfully, but afterwards we didn't manage pain well, and then they end up by having those different.
Dr. Gaston, I think the volume is still very, very low. It could be the yeah. I think
maybe I will change the headset, because
yeah, exactly. Maybe if
I can't put the loud. Let me try. Okay, may I take maybe the computer closer to me? Because, you know, do you hear me now like this?
Yes, it's better.
Now it's okay.
Okay, let me try this.
Thank you.
So, bunch of things we can do in pre-op, like education of the patient, education of the family, managing the underlying disease, like, you know, there are some medication we stop, some habits like smoking, like alcohol, and then all of those we explain to patients the risk, educate. This will have an implication in how they perceive pain in post-op, and then what is happening in intra-op, where we opt this multimodal analgesia.
Join some but this is not loud. Join some Zoom program.
Good. There's a noise. Some people are not unmuted. They are muted. They are not muted. Okay, let's continue. So if we use the multimodal analgesia, that the important thing is to improve analgesia. You know that everyone can say can treat pain, can be expert in treating pain, but it's not true. You need training. They need training. They need to understand the pharmacology. They need to understand the pain pathway. They need to understand other factors related to pain, and then how to treat. So if these things are not gone through, and we have problems, we have challenges in addressing the issue. So, like if you ask people how many people know how to do preemptive analgesia, that would be a question that everyone will be asking. So how do you do with preemptive analgesia? We do things, we give a medication before surgery, and then we decrease the intensity of pain intraoperatively. So going to pathway, like pain pathway. So we have the stimulus, and then the chemicals go along the way in the dorsal root ganglion to the spinal cord, and then go to the central nervous system. And the feedback that comes then that you experience that pain. So when you give medication, all medication have the receptors where to work there. So if you target only one receptor, for example, at the level of stimulus, at the level of, for example, you give anti-inflammatory drugs only, then you will not cover the central part. You will not cover the modulation part. You cover the ascending pathway. And then all the components, we have to be careful on the pathway, because at some point, the pain pathway, I mean, everywhere we just react on that stimulus. And then some people give paracetamol and they give NSAID like ibuprofen or something, and then they think they treated pain. With that intensity of pain, I mean, after defining the stimulus and the intensity of the stimulus. So then, where the source of pain can be, you can use other methods like compression, cryotherapy, local anesthetic, or non-steroid anti-inflammatory drugs. At the level of transmission of pain, then we use regional opioid, gabapentinoids, or ketamine. And the level of central, where we're processing pain, where we have coverage of modulation, interpretation, all of those things, perception, then you have all those medications because they have the receptors there to work on. So you understand this, you understand the relationship between pain pathway and medication you're using, considering the receptors, and then you cover everything. So you will see a list of medications that can be used for having optimal multimodal analgesia, like a regimen, preoperative identification of patients will be one thing. To see who is eligible, who is the patient who is going to have that kind of pain. So you will need a dose combination of acetaminophen or paracetamol, a non-steroid anti-inflammatory drug, dexamethasone, of course, local regional anesthesia, and you need infiltration where necessary. If you have the surgical site, you can infiltrate. And there are some other options that would be administered for non-pharmacological approach, like heat, ice compression, distraction. Where we mean distraction is like, if you have someone in the room, look back at the patient. Can people please mute, or the host can mute everyone, because this is disturbing. And the Busola, can you mute people?
Yes.
Is it possible?
Okay, I'll do that from my end.
Okay, so I was talking about this patients, about patients where there's a limitation to have access to those medications. So that's why we improve the use of non-pharmacological interventions, like putting ice, like early ambulation for some types of
I think his network disconnected, so we're waiting for him to reconnect.
Hello.
Oh, yeah.
You hear me?
Yes.
Okay. Do you see my slide?
Yes, we can.
Oh, okay. Thank you. Please. Sorry. Stop. Okay. So I was talking about this non-pharmacological approach, where I was mentioning all of these opportunities on the screen. And then let me show you some of the challenges in LMIC, where you have this was a study done to show the total opioid consumption, and you can see in the US, Europe, and other countries, or Western Pacific, or American, Caribbean, Mediterranean, and then look at where LMIC mostly is in Africa. You can see the consumption of opioids. So we can ask, what is the reason? What is the reason? And remember, these opioids are just on the list of essential medicine designed by WHO. And even if they're there, like essential medicine, people don't use them. So the presence of medication on that list does not guarantee its availability in many resources poor countries. And let's say the medications are there, people have fear to use them. But you can ask why? Why do they fear? There's a lack of education, lack of training on that. And then the fear, because you don't understand, people don't use them. And then you can see the other one, a consumption per country. You can see Canada, USA, all those countries like HIC. That's where much the difference, a big difference. And then look at Nigeria, look at India, look at Honduras. All those countries, LMIC are identified not to consume opioids. Is that because patients don't need them? Is that because the patient doesn't need to have opioids? Is that because we are controlling the pain other ways? Is that because we are resilient to pain? It's not true. It's not true. And who's gonna work on this? Who's gonna work on this? Who's gonna do this? Who's gonna do advocacy? Who is going to improve treatment availability? Who's gonna educate people? So from this, I will share our experience with this, which is actually, I think, the most important thing to know, how to address these issues, because we know our patient screams in the ward, screams in the recovery, screams at the emergency, screams in the maternity, everywhere. So who's gonna do this? Who's gonna fix this? And we're here, physicians, nurses, physiotherapists, everyone is here. So I'm going to share the experience of what we did in the hospital where I used to be. So we identified the need for effective pain management, and then to have a program because of the burden in LMIC, and especially in Sub-Saharan, where there's a poor economic growth and political, sometimes if people have security, instability, things like, and violence, all of this, access to good health care. This is one of the things that people are not even concentrating on this. So there are some of the studies where they show patients who have been treated with opioids. Some have neuropathic pain, you know, pain associated with surgery, traumatic injury, cancer, and the HIV. So it's still rampant. Even if management of pain is a basic human right, you know, LMIC is still not yet at that level to prioritize that. So the need is there. Seriously, the need for acute pain service, especially in postoperative, is there. So I ask you the question, who is going to do this? It will be a team. It's not going to be a Debusola, it's going to be an Accredited, it's going to be Gaston or anyone else. No, but a team. So we need to build that team. So this is the Rwanda experience, and I have not difficulty to do it. And we based on the pain as a fifth vital sign to add on the respiration, pulse, temperature, blood pressure. I don't know if you know about this. This was from WHO in 2000. So this is the study that was done 2012, where we are looking at a perception and perspectives of pain management, LMIC. So the big gap was knowledge. The big gap was knowledge and the experience. So the other one was 2015, where we identified that the system barrier and knowledge barrier, these two. So what we did was just to do training and advocacy. So about the knowledge, you train people. And who you train, you have to identify who. Is it only nurses? Is it only physicians? And I know some of the LMIC countries have that hierarchy of only training doctors, training physicians without involving nurses, without involving other healthcare professionals like physio, like pharmacists, like all of those, social team, like psychologists, social team, and then advocacy. For the system barrier, you have to do advocacy. So who should do this? Who's going to do this? It's a collaboration of teams. You just hand in hand, you go together, you call everyone who is involved, and then you do things. So these colors differ here as our disciplines differ. And everyone, the team is valuable. You don't have to minimize anyone because of that hierarchy that colonized some of the countries in the LMIC. So we did training. We started with training using the EPM model, some of you know, and it was easy to understand and cover the most of the matter. And so we had to involve some of the other experts in this to make sure we did that. So the training was in 2016, and then we trained 200 people, 182, and then over almost 100, more 70% were trained. That was my hospital. And on top of training, what did we do? We did give a pocket card and then wall posters with important information, how to deal with opioid overdose, how to deal with sedation, how to deal with respiratory depression. And then we have put a patient chart to revise to put documentation here. And we appointed unit pain focal point just to deal with and tell us everything. So was the training only enough?
Hello.
Hello?
Yes, we can hear you.
Okay, let me continue. So the training was not enough. It was just the training. You know, this is the gap we all have. We train people, but even if you train people, it's not enough. What is next? We associated with the coaching, we kept education, we supported, we increased knowledge, and we developed them in skills. And so this helps much. But you can see So this was like mid-2017 where we have now challenges. So we have trained people, we coach them to understand the tools, to understand everything, and then we are pushing like a heavy stone on this mountain. So only information posters, pocket cards, as well as assessment tools were available, but nothing else was available. So no standard protocol, no guidelines, no policy, no documentation. So patients are not helping at all. So this is how we started and created the guidelines, policy procedure, everything, quality improvement, standardized multimodal analgesia. So we were in contact with ANZA, Australian and New Zealand College of Anaesthetists. So that's where we started doing this, and then our first guidelines of acute pain was approved, and there was then we did trainings on that, and we talked about multimodal and preventive analgesia. We talked about these medications, and then combination analgesics and the pros and cons. Of course, when you combine tramadol and paracetamol, there are good things and the bad things. So this combination, we went through that and we trained people on this about multimodal analgesia in surgery. We're training now surgeons and people working in surgery. Just has to be evidence-based because, you know, like our surgeons say, okay, where is it written? Is it evidence-based? We have to prove with that. So this is what we did. We did a multimodal analgesia order in adults. Like you have a protocol. From theater, you have this. You have to complete this. You have a part of opioid. It should have opioid on, and all of the forms we have in the hospital. And then you have analgesics where we have non-steroid, anti-inflammatory drugs, all the forms we put there, and then paracetamol. And then we continue with the antiemetic if patients have vomiting, antipruritic if they have pruritus, and opioid reversal. We give information about how to reverse the opioid overdose and the protocol. And then the physician, surgeon, or anesthesiologist, they sign, they print, and then they put date, and then goes to recovery. So in the recovery, what happens is so-called PRN medication. Those are opioids where you don't give like every time. You have to assess patient first. So this was the plan. You don't give opioids, and then there's a reason here that we assess, and you find it was no. These are scheduled like paracetamol, ibuprofen on hours. So all these forms we did, and the important thing we did pain management flow sheet to see how the trend in treating that pain was, and we can follow after 24 hours and see what is happening, and then we cut the gap if they're compromised. So this is what we train on acute pain care, and we certify those people about the use of the guidelines. Then that was not enough. We went through the sustainability by creating a quality improvement project. So we trained on the QI and using this PDSA, act, plan, do, and study. And this was like, you have this fruit, like this plant in the fresh soil, maybe with chemicals, and then you have all of this. And then you don't water it, you don't control, you don't sustain it, you just have nothing. So this went through what is called the. Can you mute, please? Okay. So we were auditing on tool compression because documentation was key, and then pain medication conformance and dose conformance. So this was the tool. Can you mute, please? Can you mute? Okay, thank you. It's too heavy in my ears because I couldn't continue with that. Sorry. So this is what we got. We using this chart to audit the things we wanted with these variables through completion, medication conformance, and then dosage. And the data we're seeing was like on and off, up and down over the period we had. So we had to interpret that, and then finally we published a paper on this QI study. So what do we have? We have the challenges and then possible solutions, and possibly this is said in all areas, like what we have. We have heavy work healthcare providers. You can train people and give all of this, but say, okay, I have many patients, I can't do this. So what can you do with that? So always advocacy for policymakers, and there's a lack of resources to improve the quality of care. Always advocacy, always advocacy. And socioeconomic status of patients, they can't even afford the minimal requirements to treat their pain. That's where we focus on now, pharmacological approach, and then people understand that, patients understand, and healthcare providers understand. Then we have pain medications availability. That's why we should have a pharmacist on board. I don't know if we have pharmacists in theology, but I think we have them. So this, we can't do anything without pharmacists on board. And then we have to deal with over-the-counter medications, because once you prescribe the medication and the patient goes in pharmacy to get it later, you can't control that later. Because they get that medication as actual pain, they continue that at home. They create those medications due to hyperalgesia, where you can't even know. They will come later for years, being addicted, being dependent on those medications with other psychological problems. So education and advocacy. So what is next? That was our last part. We need to develop awareness. We put emphasis on awareness. Awareness. Actually, we have to tell people that we don't need patient screening in recovery. It's really sad for us sitting there and the patient really screaming, crying in the recovery, in the hospital. Day one post-op, they are in agony. They can't even eat. They can't even stand. They can't even have that deep breath. They can't even move from their bed. It needs awareness. Every nurse to know, every physician to know, every surgeon to know, every CEO to know. And then after knowing that, we just speak up. We speak up. And then we train people, we train people. Number 4, we record and we publish. So if we do this clinical research on that and doing quality improvement projects, would have a big and meaningful impact. So that was the journey, and then we did 2 international conferences about this, and we'll be happy to share some of the pictures. This was 2019. We call upon experts and we discuss all of this. We talk about things, and then this was in Italy. The first one was paving the ground for pain medicine in low-income countries. This was really amazing, and at least people have known what is pain, have known, pain, that pain exists. Yeah. So you can see, okay, that's the venue, and we had the second one with the 302 participants, 12 countries presented, and some of you were in this conference, I know. And then we had the 72 international participants. So this is what I was telling you about multidisciplinary approach. So you can see here, we are involving even religion. This guy is a pastor, and this is a traditional healer, and this is a scientist. So combining these 3 will be much better to have a good and appreciated outcome. Maybe I will share later about what is this doing for our patients. So So then we for us, it's my pain clinic where I was, and these are my team, and we're having patients in our team, and then educate together. And these are multidisciplinary. We have anesthesia, we have nutritionists, we have physio, we have everyone on the board, and then we are printing posters to educate patients, not only for us but to educate patients. So this is some of the pictures. We're having sessions we are meeting. We have social specialty and other different illnesses. So what is the key message from this presentation? Pain services are high need in the LMIC. Professional trainings and advocacy are essential. Having administration surgeons on board is very important. Collaboration is a key. Don't think you can do it by yourself. Your own institution can't do this, and you need to have collaborators. Multidisciplinary team is recommended, and a champion is needed. And I know whoever is here on this platform is a champion, want to change something, want to move forward.
I think his line disconnected again. Let's give him a minute to reconnect back. Thank you, everyone.
Sorry. You hear me?
Yes, we can.
Yes, we can.
Oh, okay, great. So we got the key message from that presentation. We've got that experience, and I think this is what I had to share, and then talk about this topic. So now, I thank you for your patience, and I think we get something. So the floor is yours to ask questions and comments before we take off. Thank you.
Thank you so much, Dr. Gaston, for sharing that enlightening presentation on multimodal analgesia. If I get it correct, just as a way of summary, you mentioned that it's an approach to pain management as a way of combining multiple methods and medications to provide relief for the patient. It's not safe for the patient, it's not safe for the hospital when patients start screaming in recovery, or patient can't even turn on the bed, or a lot of things. You can't even discharge the patient because the Aldrich score is very, very high. So thank you so much for sharing that information. I believe everyone, they've already gotten 1 or 2 key points to take home. And I want to throw it open to the house. If you have any questions, you can raise your hand. If you have any question to ask our speaker, you can raise your hand. Or if you want to show appreciation for tonight's presentation, you can raise your hand as well, or mute your microphone and speak. Let me see. Do we have anesthetists in the house? Anesthesiologists, nurses in pain management? I think we have a couple of them. I'm seeing some of them. Like, do you have any contributions, any questions, any queries, anything you need clarifications on? Let me see the chat. Okay. Anaclet, yes, thank you. You can unmute your microphone and speak.
Thank you, Mr. Gaston, for the good presentation. I really know that this is a good presentation that can even, once we need to have that training, it can take more than 3 days. But he tried to summarize and give something that was important. I have even participated in that program of multimodal analgesia in our hospital. That was headed by Dr. Gaston, but really it was not easy, because sometimes it required a change. But the good thing that you can know, pain is subjective. Do not judge some patient in postoperative saying that we have 3 patients that has been operated the same way and they didn't experience the pain like you. The pain is subjective. Anyone can have the pain on his way and express the pain, and then you have to act. So multimodal analgesia, it required a team. But first of all, after the training, the one that take the long time of the patient should advocate. Those are the nurses that have to take a long time to advocate for the patient, where the surgeon has to prescribe those multimodal analgesia. And I really know that it's work. I can confirm that multimodal analgesia, it work, it reduces the pain. When the pain is reduced, the patient will start to move early. When the patient started to move early, it will be the child to go home, and all other activity will start. So we need more training. I have seen on your chart that is in Canada, the opioid are used more than 80%. Countries like Nigeria, they don't. But I didn't know that multimodal analgesia. So it's up to us to do advocacy, training to those countries, and even to our country to do the remind, to do the training in the district hospitals and even the health centers where they receive the patient. Normally, an operator, the patient should not feel the pain. And the good way to manage the pain is not to give the painkillers when someone has severe pain, is to prevent to have severe pain. Thank you, Mr. Gaston.
Well, thank you so much for that contribution. You've summarized everything that was said today in a few lines. Thank you so much. I believe all hospitals are listening. I think at this stage of our lives, we all need zero pain, not just the patients, even the staff as well. And as Anaclet emphasized, it's a team approach. It's not one person's job. We all need to come together as a team. And definitely, as our speaker said, we need a pharmacist on board. Thank you so much. Do we have any other contributions or any other questions? I think from the chat box, someone is saying, can we have the presentation, the slides? Would that be convenient, Dr. Gaston?
So I will share the presentation and whatever platform we use.
Okay.
We can have a presentation. I'll put into PDF so that we can decrease the size.
Okay, thank you so much.
And I saw some of the patients with what is the use of dexamethasone in pain.
Yeah.
So dexamethasone as a steroid can be used to decrease swelling at certain, it depends on which swelling, it depends on how you use, depends on which dose, depends on which route, and especially for chronic pain. So first of all, the swelling, of course, and the pain, and postop pain, chronic pain has been demonstrated to have an effect on as the antiemetic drug to have effects on the physiopathology of pain, especially when people have nausea and vomiting with accentuate or give to pain. So when you alleviate that, when you decrease that, it has an effect on that pain. So we use mostly dexamethasone as adjunct medication to that. And then I've seen it using NSAIDs in ICU. So those patients in ICU are in critical conditions, and some of them have exposed to develop those kidney injury or any other problems with that anxiety, with that stress problem, having the septic ulcer disease. So it's not common to use the NSAIDs in the ICU patients. So we mostly use opioids. We can use opioids because patients are there, airway secured or can be easily secured. So that's why we jump for opioids and paracetamol mostly. And then we can use other like antidepressants, anxiolytics, and ICU. So that is one of the things we can do with ICU patients to avoid those side effects of medication for systemic. For their systems. Yeah.
Thank you so much. So dexamethasone is an adjunct. I hope that question has been answered. The person that asked that question, I think he has explained more what it implies to use dexamethasone. So thank you so much, Dr. Gaston. I think there are lots of questions in the chat box. Someone is asking, someone is saying, Jared from Kenya, I've been able to learn more in my career as a surgical technologist from Kenya. Okay, so it's just giving a feedback on the presentation, very insightful. And someone is asking, what is your experience about the use of NSAIDs like diclofenac, like ibuprofen for ICU patients?
I think that one was answered.
Yeah.
That's what I was saying.
Yeah. Okay. Yes, exactly. And then another person is asking, what is your opinion on introduction of APS, incorporating acute pain management in anesthesia department?
Okay, that's a very good question, Justin. I saw that is Justin who asked this, one of our residents, anesthesia residents. So this is very good. Actually, anesthesiologists are the pioneers in pain management, especially acute pain management, because it's after surgery or an emergency. Always have nurses. We have nurses as number one on the number one to treat pain. So the acute pain service is a multidisciplinary program. It has to be a strong program with anesthesiologists, with sometimes surgeons, and with nurses, trained nurses, experienced nurses to lead the program. So APS is very good. And I know why he has questions, because he's been at the places where they have APS under anesthesia. So it's a program under anesthesia. And then there's a chronic pain, pain clinic that deals with chronic pain. So I think it's one thing, Justin, where you can start as an anesthesiologist and then apply those people, pharmacists, and the other people can help with acute pain. So I'm rushing. I think I'll have to respond to some questions here.
Okay.
So is Alexis since 2019 for second edition European conference includes European everywhere in your facilities. Yeah, that was the challenging program because we had to talk to the hospital director, and then we didn't have someone who is really committed at the level of each hospital. But I know these things has to go through the Ministry of Health. That's what we are doing, to do the advocacy and awareness. And we are planning a campaign in Rwanda. So some other countries that need the program can maybe be part of us, and then we go with that. It has to be something from the Ministry of Health to have that power. And okay, collaborative pain management training in Nigeria. I don't know about now. I know I have some friends in Nigeria who do pain, but I think we have to start the collaboration process. And then people use they are using magnesium infusion or IV lidocaine or ketamine, a combination. So it depends on what your target. Some of them, myofascial pain is chronic pain. We can use different medications targeting the receptors. Like if I use magnesium, I won't take calcium out of the muscle cells. If I use ketamine, I'm of course targeting with the lower dose, that effect of lower dose in pain management. IV lidocaine is just to help with local pain, but also it helps with this when you use for my facial pain. Sometimes we use bicarbonate because it's been there and no oxygenation in the muscle cell, and then there's acidic there. Then we put buffer like bicarb, magnesium, lidocaine, and sometimes dextrose to boost the ATP so that the muscle contraction comes back and normal. Thank you for Sergka for that started the pain during labor. We really appreciate what Sergka. It's one hospital in Rwanda, teaching hospital that started with this labor analgesia. And then is asking how can gabapentin be used in management of chronic pain effectiveness? Gabapentin is used to address the issue of depression. Because chronic pain goes with depression. So we use gabapentin, we use anxiolytics, we use this TSA, tricyclic antidepressants like amitriptyline. So multimodal pain management approach is the key for success. The other how can we advise to the management of physical, so it's an entity of everything. If you address physical pain without touching psychological part of it, social part of it, religious part of it, if you don't do that, if you don't address the diet part of it, you can't make it. So it's entity of everything. So my apology, I'm leaving. I know you can continue with discussions.
Thank you so much.
I think I've seen it. We can keep telling later. God bless you. Bye-bye.
Thank you so much, Dr. Gaston, for the presentation.
You're welcome.
Yeah, I believe.
Welcome.
Yeah, no problem. Thank you so much. You can disconnect now. Bye. And all the
bye. Thank you.
Yeah. So thank you so much, everyone, for joining us in today's presentation. Our speaker is on the way to the US. He needs to catch up with his international flight. Thank you for listening. Thank you. And I'm going to invite Anna Cleft to give a closing remark.
Thank you, Deborah, for this time. I take this opportunity to thank Dr. Gaston Nyirigira for the good presentation where we have seen multimodal analgesia, what is it, why do we need it, and how it is used worldwide. So thank you for him, and we have to wish him.
I think it's network. Yeah, we wish him joining message to the
USA. And also thank you for our training program will continue. So I take this opportunity to thank every participant of today. Thank you for your time. Thank you for your consideration. And we will communicate to you. We will share you the slide that Dr. Gaston has accepted. And once you have the problem or any question or any addition, you may share it on our platform. Then we will send them to the speaker of today. Then we will give you the feedback.
Yes.
So thank you, everyone. And I may say, see you another day. And the presentation of today was fabulous. Thank you, everyone. And bye.
Thank you. Bye-bye. 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 Thank you, everyone.
Thank you.